Hope everybody had a nice break. We're gonna continue our educational session here with our next presenter, one of our own physical therapists here at the Sports Medicine Center for Young Athletes, Gagan Sidhu, Doctor of Physical Therapy. She completed her undergraduate degree at UCLA and worked along the sports medicine team as an intern for those years. And then she completed her doctorate of physical therapy at USC. Which one do you root for? Oh, there you go. She also completed her sports physical therapy residency here at Children's Oakland, and she recently got her board certification in sports physical therapy. So welcome, Gagan. You're all set.
And then just go forward from here. Perfect. Great, thank you. Hi, everyone. Good morning. Still morning, yes. Thank you, Tuan, for that introduction. I don't know where he went. And thank you all for having me here. It's an honor to be able to present to you all today. Yeah, let's go ahead and get started. So my presentation is going to be focusing on the lower extremity screening for knee injury prevention using various levels of technology. My hope with this presentation is that regardless of what clinical setting you work in, regardless of what resources you have in terms of the level of technology that all of you may have access to, you can maybe take away at least one thing to apply to your clinical practice moving forward. So we'll go ahead and start. I have no disclosures. In addition to that, some of the objectives I have for us today are to just be able to discuss some annual injury rates and risk factors for knee injuries, specifically for this patient population that we work with, providing advantages and challenges of assessments performed using either low or high levels of technology, and then just providing an overview of the literature discussing various injury risks screening assessments ranging from low to high technology. All right, let me figure this out. Okay, just to kind of set the scene a little bit, I love a good statistics slide. So just to kind of talk about injury rates, according to Butler et al., 2.5 million sport-related knee injuries occur in the pediatric population annually. According to a review done by the National ACL Injury Coalition, there was a 25.9% increase in average annual ACL injury rates over a 15-year period. So definitely an increase to note there. In terms of rate of injuries, there was a 32.3% increase of injury rate noted in girls sports, whereas in boys sports, there was a 14.5% increase noted. And then in terms of the specific sports that we noted these annual average rates to increase, for girls sports, it was soccer, basketball, and lacrosse. And then for boys sports, football, lacrosse, and soccer. Alrighty, so let's talk a little bit about risk factors. Before we do go into the risk factors, I think it's important to just have a quick conversation regarding what the current literature and research states in terms of when it comes to being able to screen for injuries. So in terms of the current literature, I think it's important to note that I wish there was, but there's no magic formula at this time to be able to 100% say, based off of what you're seeing, we can predict that there will be an injury, right? But instead, a lot of the current literature is basing off of these risk factors and associations off of previously injured athletes, and making those associations according to that. So I do encourage you to just keep an open mind when I am going to be reviewing different studies. I did try to include prospective studies that included uninjured individuals, but some of the studies do focus on more like associations with the risk factor. I do think that these assessments are still really important in terms of being able to identify those risk factors for your patients, for your athletes that you're working with. But I think setting the intention of not having this expectation of like, is this athlete going to get injured from what I am assessing, but more so using it as like a guideline to assess risk factors, not only for your own clinical practice, for your own clinical judgment and reasoning, but also as a way to kind of loop your patients' parents into, the plan of care as well, to be able for them to also be able to identify like, these are some of the things that I need to work on in order for me to set myself for success, essentially. So when it comes to these risk factors, I'm going to be referring to a study done by Hewitt et al. In 2019 that's talking about different risk factors specifically for ACL injuries. They start off by just kind of including a lot of patient variables when it comes down to like age, sex, weight, height, body mass, like tibia length, et cetera, especially within the patient population we work here. It's a multifactorial, approach that you have to take when it comes to these variables. There's a lot of things changing and a lot of differences seen within certain age groups. So just keeping that in mind. The biggest thing that I'm going to be focusing on is talking about strength and power, movement biomechanics, proprioception, and balance. And then one of the other risk factors was psychosocial status, which I personally won't be touching upon too much, but I do think it's really, really important. And I encourage you guys, if you want me to send any of these articles that I'm referring to, I'm happy to send those if you guys want to take a look. Okay, so again, going back to that study, the point of this study was to really establish a 5-factor maximum clinical model. They start off this article by essentially communicating that there's sometimes like an overwhelming amount of tests and assessments and things you could do to potentially screen patients and athletes for injuries, but sometimes that dilutes, like the information that you're getting or kind of the approach that you're taking. So really being able to pinpoint 5 specific factors to make that process more effective and more time efficient. So based off of a prospective study and testing they had done for 744 uninjured basketball and soccer female athletes, these specific risk factors were determined, and their intention of the study was to determine predictive mechanisms underlying increased knee abduction moment during 3 drop jump tasks. And one of the reasons why they focus on that was because there has been research done in the past that's shown frontal plane knee motion has been identified as a risk factor for ACL injuries. So to just discuss the risk factors really quickly here, and just to note, this is for primary ACL injury risks. We'll talk about second ACL injury risk in just a little bit, but they identified number 1, body mass, number 2, tibia length, number 3, peak knee abduction angle, number 4, knee flexion excursion, and number 5, peak hamstring to quad strength ratio. And from these variables, there was a 78% accounted for the variance in the knee abduction moment during landing, with an 85% sensitivity and 94% specificity. And then the second half of the article discussed second ACL injury risk factors. So there's more and more research being done for second ACL injuries specifically. This was kind of like a preliminary list they came up with, and they had mentioned that a more proper and thorough risk analysis model is still being developed for second ACL injuries, but I still thought it was important and very interesting to discuss for us today, only because we're seeing this a lot more. So I was very interested in it to just like learn more about what they were finding. So some of the variables they had talked about, one of the biggest one was noting transverse plane hip net moment impulse during the initial 10% of landing on the uninvolved limb. So essentially like a hip internal rotation moment. And I think that's just important for us if we're trying to help, a patient return back to sport. We're assessing their mechanics with certain change of direction drills, specifically, like cutting, lateral shuffle, all that. This is, I know, specific to drop jump, but still something we can keep in the back of our head, is to be able to look at the other side and kind of help identify that just based off of the statistics that we've been kind of noting in terms of the rate of second ACL injuries. So that's one of the big ones that they had noted. Another one they had noted was asymmetrical sagittal plane knee moment at initial contact. And then using two-dimensional technology, frontal plane knee excursion, noting kind of like this figure here, how they had measured that on the side. And then postural stability deficits on the involved limb. This was all with a sensitivity of 92% and specificity of 88%. Okay, so what do we kind of do with all these risk factors? How do we kind of put things together? Everyone's coming from like a different clinical setting, different clinic that they're working on, or maybe like even individually working by themselves. So I think it's important to just take time to sit down either individually or as a clinic and just kind of assess your resources first and foremost to see what are the tools or what are the resources that you have to implement some of like these assessments we're going to be talking about. And then number two, kind of create like a battery of assessments that you can pull from within each clinical setting that works for you. It can be overwhelming. There's a lot of different tests you could do, but maybe just having your personal go-tos or your clinic go-tos to be able to implement this into like your regular practice could be helpful. And then let's talk a little bit about, if we don't have all this high technology, is what we're doing just from an observation standpoint worth it and efficient? So based off of some articles I pulled from JOSPT, observational risk screening is practical and cost effective. The specificity was acceptable, but just know that there has been low sensitivity determined based off of, just being able to observe the risk. Doing observational risk screening. And then in terms of evaluations of frontal plane knee control compared to like the 3D motion analysis, which is the gold standard, there was about a 60 to 72% specificity and then 67 to 87% sensitivity. And then in terms of the different kind of technology used, of course, there's advantages and challenges associated with each one. I think using any form of low technology, it's accessible, or a lot more accessible at least. It's cost effective. You have a little bit more flexibility with space when it comes to just being able to perform those assessments. In terms of challenges, the quality of assessment can be affected by just like how much is going on, right? If there's multiple things you're trying to observe in a certain amount of time or a certain amount of repetitions, your eyes can only do so much. So sometimes that just means you need more time, you need more repetitions, or maybe you just need a little bit of help getting those points of data. Advantages of some of the high-tech assessments. Of course, 3D motion analysis is the gold standard. It can give you a really easy way to get standardized information, give you more points of data depending on if you're using force plates or whatever kind of forms of technology you have incorporated within that. And then some of the challenges, it's costly. It takes time to set up beforehand. Within our motion analysis lab, we have a dedicated amount of time to be able to set up the cameras, set up the force plates, all that stuff. So when our patients arrive, they're ready to go. And then within the motion analysis as well, we have to do multiple repetitions to just get the picture that we need for our reports. And then, of course, if there's force plates in the ground or if there's cameras on the wall, you're pretty restricted to where you can perform these assessments. So yeah, there's pros and cons to both. Within my previous clinical experiences here, I'm fortunate enough to be able to use our motion analysis, but sometimes you don't have that, right? So what are some of the things you can use if you don't have these fancy cameras? iPad, iPhone, yours or your patient's. You can record using videos. You can slow it down using that thing on the bottom. I don't know what it's called. And use those kind of, more readily available technology to your advantage to just capture maybe what your eye can't do in real time. And then I have used huddle technique pretty consistently in my previous clinical experiences as well. One of the reasons why I really like huddle technique is because it gives you an option to measure using one of their features, which is like a goniometer. So it can kind of give you more objective angles and measurements if you're trying to track a certain movement, or in this case, even track more like real time in the sports setting. So yeah, just wanted to kind of like bring that up in case you all are looking for ways to, perform some of these low-tech assessments if you don't have access to those fancy cameras. Okay, so some of the assessments that I'm going to be reviewing today, we'll start off with the low-tech side, talking about lower extremity strength, drop vertical jump, the LESS, Y balance test, FMS, hop test, and then the yo-yo intermittent recovery test. In terms of our high technology assessments, these are the 6 assessments that we perform in our motion analysis lab here: step down, drop jump, triple hop, deceleration, lateral shuffle, and cutting. So again, I'm going to be pulling from different studies here. I tried to highlight some of like the cutoff values or like the really big take-home points in terms of what I would like for you guys to kind of hone in on with these specific studies and specific assessments done. So we'll start off with a squat 1RM. A study done by Augustin et al. Assessed a lower extremity muscle strength and the influence it has on traumatic knee injuries in the youth female and male athletes. Their study concluded that the weak strength group or decreased strength group had a 9.5 higher odds of having a traumatic knee injury, as well as the weak or the decreased strength group had a 7 times higher odds of having an ACL injury. What they're basing their cutoff value from is if your 1RM squat is less or equal to 105% of your body weight, you're categorized into the decreased strength group. But if you're above that, then you're in, I guess, the other group, you could so call it. But I do want to note that this cutoff value is specifically identified for the female athletes that were in this study. There was no strength injury relationships observed for male athletes. So I think this is a good takeaway, at least something that like I feel like I would be applying to my patients that are females within this like patient population, that this is like a really easy thing. And of course, depending on where you are within like your rehab or in your treatment plan of care or whatever it is, if you can't do a 1RM, there's ways to like calculate that based off of like your 10. That's okay, yeah. So it's essentially a squat, your maximum, 1 repetition maximum for like a squat. Yeah, I apologize for not typing that out. Yes, yeah. So your maximum you would be doing. Okay, and the next study I'm going to be quoting a couple times here, but in a prospective study done by Collins et al., 322 elite and junior female footballers participated in a preseason field-based test. Out of those 322 athletes, 15 non-contact ACL injuries occurred during the follow-up period. They concluded that one of the associated risk factors found within the specific group for an ACL injury was a lower hip adductor to abductor strength ratio, and they used our very own valve force frame to be able to get those specific numbers. Alrighty, so let's talk about the drop vertical jump. This is an assessment that I do think there's a lot of research on. There's a lot of different studies that have been done specifically for this assessment, and there's a lot of kind of mixed conclusions that come from the specific assessment in terms of whether it's concluded that this jump test is associated with ACL injury or not. So this specific study that I'm going to be discussing It's picking up on certain metrics associated with ACL injury, but again, keep an open mind in terms of like the research out there, in terms of the associations. But I still think this was good to just bring up because not only are we talking about the knee abduction angle, but there's other really good points that the study hit on that we can kind of keep in the back of our mind when doing some of these assessments. So some of the metrics included a knee abduction angle at landing that was 8 degrees greater for the patients that had an ACL injury. A stiff landing with less hip flexion was noted, and we'll talk about that when we go into like our higher tech assessments as well, and the importance of that. A greater peak external knee flexion moment was also noted, and then a higher landing air scoring system score was also noted for those patients. Again, I do think despite the mixed conclusions with this specific study and the specific assessment, I think it's overall a really good assessment tool to use because it gives you insight into maybe like some of the other change of direction mechanics that you might find down the road. And it's also a really good one to use if we're only at the stage where double leg plyometrics might be appropriate at this time. Maybe the patient's not ready to do hop testing where you're isolating one leg at a time, but just kind of gives you something to work with. And then also kind of helps you guide, like these are some of the foundational movements that, some of the injury prevention programs are really focusing on, like the FIFA 11 Plus and all of that. So can kind of help guide your clinical reasoning on like pushing some of those programs for these patients and kind of educating them on like why it's important. Okay, so talking about the landing air scoring system, just to kind of loop in the previous slide, what they had found. So the landing air scoring system is a tool used to assess jump landing mechanics. The validity for this assessment is moderate to excellent compared to 3D gold standard motion analysis. Within this assessment, there's 9 different categories to assess. I know it's hard maybe to like read the fine print, but some of the things that you're observing, and it tells you what you're observing from the side view, what you're observing from the front view. It includes stance width, maximum foot rotation position, initial foot contact, maximum knee valgus angle, amount of trunk lateral flexion. From the side, you have initial landing of the feet, amount of knee flexion displacement, amount of trunk flexion displacement, total joint displacement in the sagittal plane, and then your overall impression of the jump. It requires you to do multiple repetitions so that you can get multiple views. According to Fox et al., this was one out of 5 ACL injury screening methods identified. So there's multiple studies kind of pulling this assessment in. And then this is not a cutoff score, but based off of a study I read upon from Schweizer et al., the score of 6.24 was measured for injured athletes versus 4.43 for uninjured athletes. So it's at least something to kind of give you guys like an idea of what that difference is, and if you are creating goals for your patients with some of these assessments, or you want to see like how they progress over time, it's good to just have something versus like what should the score be. Yeah. All right, and then moving on to lower quarter Y balance test. This is also an assessment that has a lot of research out there, and I wanted to just include a couple different objective measures and associated risks based off of some of like the studies that I'd read upon. So according to Scott et al., the Y balance test has good inter-rater and inter-rater reliability. According to Plisky et al., an asymmetry of 4 centimeters for the anterior reach direction indicated being 2.5 times more likely to sustain a lower extremity injury. Similarly, for the posterior medial direction, according to Gano et al., an asymmetry equal or greater to 4 centimeters indicated being 3.86 times more likely to sustain a lower extremity injury. According to Butler et al., the cutoff composite score was 89.6% for the college football players they specifically assessed. So a little bit on, the older side in terms of like the adolescent population. And lastly, according to Al-Khatami et al., athletes with a posterior medial reach score of less than 97.89 and posterior lateral reach score of less than 92.88 had a higher risk of sustaining a lower extremity injury. Okay, and then functional movement screen. Unfortunately, just with the time, we won't be able to review like which specific movements are in each screen, but I highly encourage anyone who's interested in the Y-balance test, FMS, and a couple more of like the low-tech assessments to go to our workshop this afternoon led by Sean and Michael. I don't know where they are. Yeah, just to kind of continue the conversation about low-tech assessments, about current literature, all of that, and they'll help kind of break down those movements. But according to Benazza et al., the functional movement screen has excellent inter-rater and intra-rater reliability, and a composite score equal or less than 14 has a higher likelihood of injury. Oops, sorry. All right, and then going into some of the HOP testing. So going back to the Collings et al. Article, that specific article, some of the other metrics, they identified front plane knee and trunk kinematics were associated with future non-contact ACL injury, and then greater dynamic knee valgus and ipsilateral trunk flexion increased the risk of subsequent non-contact ACL injury. And then according to Katsufaki et al., I wanted to just kind of touch base about the different HOP tests that we perform within the clinical setting. So vertical HOP versus horizontal HOP. I think it's important to just kind of consider and think about the intention behind each HOP test. Yes, there's parameters and there's scores and limb symmetry index that we're trying to push our athletes and patients to meet, but what is the intention behind what we're testing with each specific test? So based off of this study, they found that the vertical HOP test has similar contributions from the hip, knee, and ankle for both the takeoff and the landing, whereas if we're testing horizontally, a horizontal hop distance was determined by the hip and the ankle primarily, and the landing was mostly performed by the knee. So I think it kind of gives us some more insight into when we are doing these testings, the scores that we're picking up on if an athlete is doing maybe not as great on one test versus the other, that can kind of allow us a little bit more leeway to sit down and think and identify maybe the certain joints that are most responsible for, you know, the limited performance side to side, and just kind of give us a little bit more insight into getting a little deeper and maybe being a little bit more specific with our plan of care going forward if, you know, asymmetries or a limited score side to side is noted. Okay, and then lastly, in terms of our low technology assessment, I'm not sure how much your patients would love if you had them do this, but this is the yo-yo intermittent recovery test. It's limited to a beep test, but it's testing your aerobic capacity. I thought this was a really interesting study, Augustin et al., that touched upon this in terms of identifying this test as like a way to test for risk, like being a risk factor. So it concluded that a lower intermittent endurance capacity was a risk factor for traumatic knee injury for youth female athletes. They concluded that a total distance of 860 meters or less increased your risk of injury. And then they also noticed an increase in score by 100 meters decreased your knee injury odds by 30%. So it's something that I think could be done, you know, on the field as like a preseason assessment, or, you know, even within a clinical setting. I think it's appropriate, and then it gives like your patient something to work on if, you know, they're wanting to work on this. Yeah. Okay. And then moving on to the second part of this talk, we're going to talk a little bit about our motion analysis lab here. So we, within our clinic here, do two-dimensional video motion analysis. We talked about the assessments today. I'm going to be showing you guys videos of our drop jump, deceleration, lateral shuffle, and cutting assessments. According to Lopez et al., 2D motion analysis has good inter-rater and intrarater reliability for frontal plane kinematics. And then according to Schur et al., compared to 3D motion analysis, there is moderate to strong validity in the sagittal plane, but poor validity in the frontal plane. Now, I also want to note some of these marker placements. You could very easily reproduce this within like a clinical setting. If you do use the apps such as like Huddle Technique, I think you can get these neon stickers and throw them in these different landmarks and then still be able to kind of capture that through your phone. And yeah, we're not using like the high technology, but at least it kind of guides your eyes to those specific landmarks and making it a little bit more obvious. And then, you know, asking your patients to make sure like the area we're looking at, so for the knees example, like they're exposed, you're wearing good shoes, all of that is important. So the 4 marks, or for the 4 markers, are at the greater trochanter on both sides, the center of patella on both sides, lateral knee joint on both sides, and lateral malleolus on both sides. Okay, I'm really hoping this works. Can I get some help trying to press play on this? Sorry. Or maybe we can just exit and then I can.
Yeah, if you want to get out of here.
That might, yeah.
Okay. And now we're moving on to questions? Or
Oh, I was just going to try and play the videos, but it
Okay.
wasn't. Yeah.
Let's go back to here. So you should just be able to have it. If there's a video, there. Okay.
Yeah, so I'll go here and then the video pops up.
Okay, so it's connected to Drive. So, okay. So to get it, the video isn't actually loaded on there.
Oh, it's not, okay.
Yeah,
Okay.
so
This is probably not.
if you got more to go through, I can load it and bring it back to you.
Okay, that was kind of the last part, but I'll at least chat about it and then, yeah,
Okay.
there's a workshop here. Okay, if you can, but if not, we'll be. I'm really sorry, everyone. As we're trying to see if the videos will load, I'm gonna just kind of walk you guys through some of the important things that we are looking at in terms of like the mechanics, in terms of the positioning, and the different things that we're kind of observing. So the drop jump assessment is the first one that I was going to discuss. A 12-inch box is what we use, and from like the less assessment that we talked about as well, that's the height that they also use. So essentially what this test is, the patient's cued to jump down. You can see our force plates down here. We have the step here, and then the patient's right off of the edge there. They're cued to jump down onto the force plate and then jump back up as high as they can. So if we were to pretend like this patient just jumped off the box, some of the things, let me see if I can go back and just, yeah, okay, so we'll just pretend like this is the patient. In terms of like the mechanics that or the different things that we're trying to look at, we're looking at trunk stability, we're looking at hip strategy, which would be viewed from the side, and then we're looking at hip stability, which is specifically talking about that knee valgus angle. With the video, the patient had a pretty significant reduced knee window. So very similar to actually this image here, where you can see that knee falling in medially. And then if you could maybe like imagine this trunk leaning towards the right side, that would be discussing more of like the trunk stability aspect. And then if we were to view this from the side, so here, if we had this view, right, we can kind of zoom in and see the hip flexion angle here, and then the knee flexion angle there. So those are some of the three things that we're looking at within that motion analysis. In terms of the knee separation degree, our goal is to have a minimum of 80% of separation. So with the video, the patient definitely had a lot less. And that specific criteria is based off of studies done by the Cincinnati Sports Medicine Group that we refer to for our motion analysis reports when we're trying to go through that. Yeah. Hoping it magically works, but I don't think it's going to happen. Okay, and then in terms of deceleration, so deceleration is essentially mimicking a change of direction moment where a patient's running forward and then has to change directions really fast, starting to pedal back. So with this video, we would cue the patient, okay, you're gonna run, plant on that force plate, and then start pedaling backwards. So if you could imagine the patient going into almost like a single leg squat or like a very deep lunge, we're trying to assess, again, that hip stability angle. So is that knee falling into like a medial collapse with that dynamic knee valgus? Where's the trunk in relation to the patient's hips? And then from the lateral view, we would be seeing how low essentially are they getting? What's the hip flexion angle looking like? What's the knee flexion angle looking like? And then also just generally like what's their back position? Are we like really rounded and really anteriorly or posteriorly tilted? What does that look like? And that just kind of gives us different things to score them on within our motion analysis report. And then you can kind of see a pattern. So a lot of the things that we're trying to highlight, trying to look at are essentially the same, but it's just different movements, different forms of change of direction, which is really important for our athletes that are participating in sports that require change of direction. So with the lateral shuffle, here we have the lateral view. We can kind of like, if that patient was already on that first plate, we can see the hip flexion angle is really not that much. That knee flexion angle can definitely improve as well. And then her trunk looks pretty good. But then if I were to see this from the front view, that could tell me a little bit more in terms of that frontal plane movement, as well as that knee valgus angle. And then cutting. So this is like a front view here. Again, imagine this patient planting their foot on this force plate and then cutting towards their right, or actually I'm not sure what's reflecting, but like towards their right. Again, we're taking a look at hip stability, trunk stability, and then from the lateral view, seeing what that hip and knee flexion angle look like. And a lot of this, like with the low tech assessments we were talking about, that's also within their studies, like talking about stiff landing, talking about that knee abduction movement. All those things are kind of carrying over into these high tech assessments as well. And then I believe this is the lateral view. Yeah, so this would allow us, even starting off, so if she were to plant here, we could tell she's really, really upright. So that would cue us into that knee and hip flexion angle in terms of that aspect. Okay, I'm really sorry that the videos didn't end up working, but great news is that we also have a workshop for our motion analysis lab led by Niraj Bahethi, one of our physical therapists that has a lot of experience within our motion analysis lab. So I highly encourage you guys for a step-by-step guide to go to that workshop if you're interested in learning about more. These are my references. I want to thank you all so much for your time and attention and for your commitment to being lifelong learners just by being here today. I know I'm running a little overtime, but yeah, thank you so much. My email's here in case anyone has any questions. I'll be around at lunch as well.